everybody. I propose we start with the session of Dr. Leemans, Charlotte, about glomerulopathy and genetic.
So thank you for having me here and for the kind introduction. So the two subjects I'm going to talk about today are in the next 20 minutes is what's new in primary glomerulopathies and what's new in kidney genetics. The first subject I wanted to talk about, which is hard to ignore, is the latest clinical trials in IgA nephropathy. I think this is the first thing that popped out when walking around ASN, is that we couldn't not see all the new treatments that were available in IgA nephropathy. So this is a slide from the presentation I'm going to talk about in a few minutes, but just to show you the number, the amount of new medication we now have or who are now in the pipeline and waiting to hopefully be approved very soon. So I'm going to start talking about this presentation from Diana Risk, who is from the University of Alabama in Birmingham, which was a sort of resume of emerging therapies in IgA nephropathy. So this is a quick reminder of the physiopathology of IgA nephropathy. So this is what allowed us, allowed the nephrology community to find new treatments, is that the pathophysiology was already quite well known, that and the Kidney Health Initiative. And so what do we know is that some different antigens are going to come on different mucuses, whether it's the oral or digestive, which will then secondarily lead to lymphoid proliferation with notably the APRIL, which is a B enhancer, which will then lead to the production of anti-galactose deficient AGA1, which will then secondary lead to the formation of pathogenic IgA1 with immune complex with primarily IgA but also IgG, and those will secondary deposit into the kidney, leading to the disease we know and study. So this then allowed the development of new medication, but also the reuse of medication we already know. So this is a modified slide from already 2015, and you can see all the new medication that have now been added. So what were the latest 2021 KDIGO guidelines on IgA nephropathy? Well, very little, if I may say so. So we knew we could have comprehensive supportive care with ACE and diet restriction, but then we were very limited, and very quickly we had to consider enrollment in clinical trial for those patients. Sometimes in patient with preserved renal function, we could consider glucocorticoids, which showed limited results as the testing trial show, which I won't be talking about, unfortunately, today. Just a quick note that most of the studies all of the studies I'm actually going to talk about are not relevant in secondary IgA nephropathy. So that was the limit we had in 2021. And that, of course, changed very quickly. First with the arrival of those two big studies, so DAPA-CKD and EMPA-Kidney, which showed a big reduce of the primary composite outcome by 71%. Please just note that those are not our typical IgA nephropathy patients with lower kidney function, higher proportion of diabetes, and slightly older than our typical patients. So this and the EMPA-Kidney, with also a very positive result, led us to add the fluorescence to our treatment. But then what has arrived since then? So the next big study I think you've probably all heard about by now, I'm sorry for the repeat, is the PROTECT study, which was also shown in the high impact clinical trials. So this was the first result with the primary outcome at 36 weeks, and what we saw was a big reduction in the primary outcome, which already in February led the FDA to an accelerated approval for the FELSPARI. We since then very close by, at the date of the ASN had the following results. So here it's for the proteinuria. We saw there was a nice reduction in the irbesartan group compared to the irbesartan group, and so the medication is in good sign for approval. Well, has been approved by the ADA. We are still waiting to see if it will be approved by the European Medical Agency. Here we see the results for the kidney function. So it missed the outcome. One of the hypotheses is that it probably is due to the acute reduction at the beginning. Maybe if we take out that from the equation, we do have significant results. But it missed that out point at 2 years. So this is what I wanted to say about the PROTECT. The next one is also a phase 3 trial, which looks at localized steroids. So Nefecon is a novel targeted release formulation of budesonide that specifically affects the ileum and directly on the Peyer's patch. It's mostly the same cohort, well, a very similar cohort to the ones I described previously. So IgA nephropathy rapidly progressing, and they looked at Nefecon 16 milligrams compared to placebo for the 9 months. The outcome was positive, with a reduction of the proteinuria, which then also allowed an approval for Tarpeyo in the US, but what we know as Kingpeyo here in Europe. Here's another slide showing the results. So what we see in gray is when the trial stops, and what we see is a significant reduction both in proteinuria and in a reduce in eGFR. The next one I wanted to talk about is there a phase 2, which is the ENVISION trial, which is about sibeprenlimab, which directly targets and neutralizes APRIL activity, which is, as I showed previously, a direct enhancer of B lymphoid activity. And in this phase 2 multicenter double-blind randomized placebo-controlled, it showed that, so it was conducted around 98 centers across 15 countries, and patients were randomized to placebo versus 2 milligrams, 4 milligrams, 8 milligrams during 4 weeks. So the first thing it showed was that there was no severe adverse effect, and that the list of adverse effects was very similar between the two groups, and that there was a significant reduce, especially in the 4 milligrams and 8 milligrams group. And of course, phase 3 studies are still needed. Here you see the data directly on the GFR, but as I just said, further studies are needed before approving the medication. Here you can see, still with the same medication, a nice reduction in the biomarkers, not surprisingly on the APRIL, which is directly linked to the mechanism of action, but also in galactose-deficient AGA1. So here, I just wanted to put all the trials. I'm not going to go into detail in all of them. Of the other medication, Artemis has been already stopped due to the lack of results, and Align and Applause show promising results. So what can I conclude at this stage about IgA nephropathy treatment? I think you'll all agree in saying that it is rapidly changing, and the future is full of possibilities. We'll see, but of course we must already decide what will be our strategy. Are we going to have different treatments at different stages? Are we going to have different treatments at the same time? Are they going to be all for a lifelong treatment, or are we going to be more focused on flares and relapses? And as always, when talking about IgA nephropathy, one of the questions is, well, what about the children? Studies are being started on the specific cohorts to see what the results are there. So that's the first subject I wanted to talk about. The second one is maybe a bit more directly clinical, which is SGLT2 inhibitors and primary glomerulopathies. Is it time? I wanted to do a review of this presentation from Paola Romagnani from the University of Florence. And I think it's a very interesting question because I think based on those two studies, the first response we all had was, okay, let's put SGLT2 inhibitors to all our patients. And the presentation could stop here. But what we observe in clinical practice more and more, and so she took this example in a way of rounding her presentation, is that, so if I take this case, for example, so we have a boy of 21 years old with a BMI of 18 who's had a genetic diagnosis of Alport 10 years ago, at age 10, sorry, and who 8 years ago was referred into the center with a proteinuria, was started on treatment with RAS blockers, which showed a nice reduction in the proteinuria, but then secondly, due to MPA kidney and diabetes CKD, was put on dapagliflozin and with no response. So the question was, why don't we have any responses? And so they went back to the different studies to try and find answers. The first thing they observed was that obviously we had a huge proportion in those two studies of diabetes, 67% in DAPA CKD and 46% in MPA kidney. And the first conclusion, so they had a high proportion of diabetes, but also with a high BMI in both of 29, and patients with already a GFR reduced. And so the first conclusion they draw was patients of DAPA CKD and MPA kidney cohorts are affected by CKD with sodium retention and volume expansion. They looked also at post-hoc analysis because we could see they looked in the group of BMI under 25, and it's true that we still had a result on the drugs, but what we could see was that in that cohort with BMI of 22, there was still 56% of diabetes. If we look at the SUSA analysis, which looked at the effect on FSGS patients, again, the conclusion was the medication works, but if we look at the patients, we had a BMI of 30 and an eGFR of 40. Again, so they looked through a different range of primary glomerulopathies, and the conclusion was the same if we looked at the cohorts, BMI of 29, 77% of overweight, and 40% of obese. So what can we conclude at that point? Of course, it's undeniable SGLT2 have proven efficacy on top of RAS blockers for CKD patients with sodium retention and volume expansion. So patients with glomerular hyperfiltration, independently from the type of glomerulopathies. And we can also say that the majority of CKD patients, including those with primary glomerulopathies, are overweight or obese or have diabetes. These are the statistics from the States, and important geographic differences apply. So they looked a bit at the provenance of the patient in the different studies, and what we already show is that the results for Europe, where we have maybe lower rates of obesity, was different. Sorry. You could answer to that, okay, but China and Malaysia, we still have results, and Chinese people are not necessarily obese, but China was pooled with Malaysia, and as you can see on this slide, there's a high rate of obesity actually in Malaysia, but also of diabetes. So going back to the patient, is the reason why he had no response because he was thin, underweight, no diabetes, early CKD, so no sodium retention and volume expansion. The answer for the moment is, should SGLT2 inhibitors be given to any CKD patient? Yes, to those with CKD 3 to 5, including those with primary glomerulopathies, but that also have diabetes, overweight, obesity, and heart failure. There's no yet evidence in patients with CKD 1 to 2, no proteinuria, no diabetes, lower BMI, children, and no signs of hyperfiltration. This is a resume of what I just said at the moment, so you can see clearly, yes, for CKD 3 and 5, diabetes, BMI 25, or heart failure. Unfortunately, sorry, I couldn't go through her whole presentation, but she also showed how probably biomarkers are coming to define the different, well, to separate maybe our patients between active and chronic, and probably SGLT2 inhibitors are not so useful in our patients who are active, which will quickly respond to steroids. So the conclusion, I think, from this presentation is specific clinical trials are needed on the type of patients. So the one with CKD 1 and 2, no diabetes, lower BMI for SGLT2 treatment. In a few minutes that I have left, I wanted to talk about the other subject, which is what's new in kidney genetics. And I wanted to talk about this Renner Care, which actually came out after the ASN on the beginning of December, but we had a few previous, fortunately, during the ASN. So I wanted to go very quickly, because in the time I have left, on this presentation from Neridal from the Mayo Clinic, which who is also one of the main author in the study, which is incorporating genetic testing into clinical practice. So what do we do for the moment? So the KDIGO from 2022 tell us who to test. So patient with an increased likelihood of genetic diagnosis, whether it's or a young age onset, family history, cystic or anatomic abnormalities, unclear etiology of CKD, extrarenal manifestation, but also patients who are potential donors with a family history, or people with severe CKD in whom a biopsy is not indicated, with also family history. A big principle in genetic testing is also the question of actionable genes in kidney disease. So actionability refers to the potential for genetics test results to lead to specific clinical action for prevention or treatment of a condition. So, for example, conditions amenable to specific disease-modifying therapies, avoidance of prolonged immunosuppressive therapies, such as an Alport, conditions we know are at risk for recurrence after kidney transplantation, conditions amenable to specific screening for extrarenal manifestation, and of course, genetic testing is relevant for reproductive counseling. And so what was a bit new in the study, so what they did genetic testing with a panel of 385 kidney gene panel, and they asked questions to the physicians before the test and after the test, and the big question was, will that change the management of patients having the tests? And the results were quite interesting. So the first thing they said was that the actual yield of the test was quite high, with 20% of yield from the genetic testing, with higher yields from cystic nephropathy and lower for some. But 20% is already very impressive. In comparison for cancers, we're often at 5-8%. And what was also interesting is that the diagnosis was either new or reclassified in up to 50% of positive cases. What they mainly showed was that genetic testing had an actual clinical impact in patient management, and that what was interesting was that it changed the clinician practice management if the test was positive, but also if it was negative. And they showed that across a big number of nephropathies. And just to finish on genetic testing in Belgium, it's available, it's not so costly now for the patients, and we have also the clinical gene panel. So I think the message is that we need to test more patients. Thank you very much. I wanted to thank especially the GNFB for giving me the opportunity to go to the ASN. It was a very interesting experience, and I was very lucky, and it was very educational. Thank you very much.
Thank you, Dr. Leemans and Charlotte, for your very clear and overview of this very changing landscape of IgA nephropathy, and to recall us that glyphosins could be not the miracle pills in everybody. I don't know if from the audience, if there's any questions regarding the presentations of Charlotte. All was so clear. Professor Jouret.
Thank you. Thank you very much, Charlotte. It was very interesting. I was wondering whether they discussed during the ASN the position of the direct genetic testing versus kidney biopsy, and if so, in which clinical scenario genetics may replace kidney biopsy. Was that discussed during the presentation?
Yes, so it was discussed in a few presentations. I think the main indication remains when there's a strong indication that there's going to be genetic illness, and especially when there's contraindication to biopsy. And also in CKDs, which are already very far off, like stage 4 or 5, where probably the biopsy will not give any results, where there's too much fibrosis, for example. And there we know maybe the genetic testing is going to give us more information. And there was another very interesting presentation which made the economic argument. And so in a few diseases, it's starting more and more to be accepted that, yeah, we're going to bypass the biopsy for things like ARPORT, which have maybe normal still function, or even an IgA nephropathy.
So, did they give some explanation why the overweight people do better with the DAPA and the SGLT2? Is there a reason why overweight people have a better outcome with the treatment and the thin people not? Is it due to?
I think it was due to the overvaluation we have in obese people. I think that's what they were advancing.
But the underlying mechanism, is this explained? Could it be due to the fact that there is more hyperfiltration in these people?
No, so you mean the mechanistic behind the hyperfiltration?
Why the overweight people do react better on the therapy?
Apart from the hyperfiltration, no. No. What they did do, there was a few slides, unfortunately I didn't have time to put, is that they say that if the effect is there, it is due to the proximal tube. It's not, they showed that there wasn't an effect of the drug we maybe don't know in some other cells. When they look, it's very specific to that part of the kidney. So the effect is directly linked there. Why? We don't know. But they show that it's there. It's directly in the tubule, but no.
I have one follow-up question on that. Is when you say that a child has the proteinuria did not decrease after 1 year, is this sufficient to say that there's no response? Because I sometimes have the impression that when you start SGLT2, that the effect on proteinuria is not very spectacular. But we do see a difference in evolution of the GFR with the medication, even if the proteinuria is not that excessive. Do you think that there might be other mechanisms in play that you cannot see in 1 year with a child, for instance?
I think maybe, of course. That's why at this point it was very descriptive. And of course, in doubt, we should continue them and still put them. But I think the bottom line was we need more clinical trials with specifically that cohort. But of course, it could be a possibility that it's more long-term effect in that population.
Yes, and it has been argued that the initial GFR slope could predict the secondary subsequent reduction in proteinuria. Do they speak about that?
Here she didn't talk about it, no.
Okay.
In that specific presentation, no.
Yeah, and they present the glyphosine like also for people who have high risk of cardiovascular disease, but like primary prevention for those people, those patients. But do they speak about the secondary prevention, cardiovascular prevention for people who already have a myocardial infarction of established cardiovascular, because it was a lot of people who have cardiovascular disease who also were embedded in the studies, because she speak about obese and diabetic patients, but people who already have cardiovascular arteriopathy and so on. Do they speak about the benefits to?
So you mean that the effect wouldn't be directly linked to the BMI and the obesity, but that we would have an effect more on the cardiovascular risk?
Even in patients with established cardiovascular disease?
She didn't go into details on that particular reason, it's true. So it could be a direct, it couldn't be a causative link, it could be indirect. Yeah.
Thank you.